tomorrow morning's lecture, a lot of it is some of the stuff we went through today. So I think it'll be good to reinforce that. Last night, I did, actually, when I went back up there, I asked Campbell to re-upload to D2L the changes, so you should be good to go. Last night after I finished working on the lecture, I said, that Shameless, that show we mentioned the other day, starring Nikki Rubin. I swear that is you. And what a bizarre show. Have you guys seen it?
No.
It is truly bizarre.
Yeah, Nikki, tell us about it.
Ain't nobody got time for that. Ain't nobody got time for that.
It was, really funny. The guy that was, an older guy, he did a movie here in Oklahoma a year or so ago.
Brad Pitt?
I can't remember his name, he's a really,
William H. Macy.
he played in this movie years ago. I think the name of it was The Cooler.
It's William H. Macy.
What's his name?
William H. Macy.
Yeah, William H. Macy, yeah. What a great actor that guy is. Just truly bizarre though. Shameless, it's only, I know.
Oh, weird.
Showtime.
How do we get that channel?
We get
We got basic.
You get Showtime, but you don't get ESPN?
No, I don't get ESPN either.
No, we got ESPN, will start charging you for it. I couldn't tell you.
We're all on
I guess we're off on a tangent, I don't know.
We don't need to get ESPN.
Anyway,
That sucks. Yeah.
we're gonna talk about the brachium and the elbow today. And on one of the cadavers, I'm going to take the elbow and dissect it down to the joint. That way you can see the ligament that I'll be talking about in just a minute. I don't think it really does that much good to do that with the shoulder unless you want to see the articulation with the glenoid. There's really not that much to see in the shoulder. The bones here we're going to be dealing with today are, of course, the humerus and its articulation with the ulna and the radius. The different pieces and parts to the ulna, the most prominent feature of the ulna is the olecranon that you feel back here. It moves in an anterior and posterior direction, or flexion and extension direction. And as you fully extend it, the olecranon itself goes up into what's called the olecranon fossa of the humerus. It's a fat-filled fossa on the backside of the humerus. Remember?
This is random, but when you hit your elbow, what are you hitting that hurts so bad?
That's the olecranon.
Okay.
That's the olecranon. Now, if you hit the medial aspect of it, that's the ulnar nerve. That's the funny bone, is the ulnar nerve as it wraps around your elbow. You know about the capitulum and the trochlea on the humerus, the epicondyles also I mentioned yesterday, the medial and lateral epicondyle. On the radius, there's a tuberosity, a very prominent tuberosity for the attachment of the biceps. We'll talk about that in a second. And the head of the radius is interesting in that it's a nice flat cup-like structure. It's very obvious. And on the distal end, of course, of the styloid process that I mentioned yesterday. On the next slide, what we have here are the three ligaments that you would be responsible for. And they're very easy. On the radial side, there's a radiocollateral ligament. The radial side is your thumb side. So in the anatomical position, this is the anatomical position. So the radial side, the radius articulates with your thumb. thumb side. So connecting the humerus to the radius is the lateral collateral ligament or the radial collateral ligament versus the one that is on the medial side or the ulnar collateral ligament. You'll see those as bands stretching from the humerus over to either the radius or the ulna. Okay? The third ligament that you should be aware of that's clinically important in this area is the ligament that goes around the head of the radius and keeps it locked in place. That's called the annular ligament of the head of the radius. Those three are the ones you need to pay attention to. You see the annular ligament here, and you see the collateral ligaments right there. Okay? On this slide right here, this gives you the arterial supply of the region, and it's actually quite simple. We know that this is teres major, and you can see in the slide why teres major is not part of the rotator cuff. It's too far down on the humerus. It's not really up at the joint itself. So the axillary artery becomes the brachial artery when it crosses teres major. The brachial artery descends on the anterior part of the arm here, medial to the biceps. It's one huge branch is called the deep brachial artery or the profunda brachii. You can call it either one, deep brachial or profunda brachii. I don't care which one. Now you're going to also run into small muscular arteries because all of the different heads of the muscles will have their own arterial supply off of the brachial. Don't worry about naming those. If you had to name them, it would be the artery to the biceps brachii short head, or bicep, triceps, or whatever. So we're not going to bother with naming them. The only two named arteries that we're dealing with here are the brachial and the deep brachial. Now, once it gets down to the elbow here, it divides into a radial and ulnar artery. The radial goes down the radial side, ulnar the ulnar side. Very obvious. Now, this division here, this bifurcation, in some cadavers will be midway up the arm. The split will be up here. But most of them, it'll be just past the cubital fossa. That's where the split occurs. The thing about the elbow, and it's the same with the knee, is there is an extensive collateral circulation around those joints. And you see all these collateral vessels that come off either the deep brachial or the brachial itself and the radius and ulna that go back up, either recurrence or collaterals coming down that supply the joint from the front and from the back. And the reason is, if you bend that joint, you're going to cut off, you're going to pinch off the blood supply from this side, so you got to have blood going to the joint. It'll just get from the other side. Versus if you have your joint in another position. It's the same way with the knee. And you're going to see that later on. I don't care that you know these vessels. What I do care is that you understand and appreciate that there's a collateral circulation around the elbow. You'll find a radial recurrent artery, it's pretty large, and then there is a recurrent off of a branch of the ulna. Now, one artery I want you to find, though, is the ulna has this branch here that goes, so the ulna will be right there. There'll be a branch headed laterally. It goes deep in the forearm. That is called the common interosseous artery. That common interosseous artery right there will divide into an anterior and posterior interosseous. The anterior and posterior interossei run right on the interosseous membrane. So just as a jump start on tomorrow, the anterior interosseous supplies the deep muscles of the anterior compartment of the forearm. The posterior interosseous supplies the extensors. It's that easy. The radius and the ulna we'll pick up tomorrow down in the wrist where we go, start going through the blood supply of the hand. It's a little more complicated, but not much so. Any questions on the vessels? So the ones I want you to find today would be the brachial, deep brachial, radius, ulna, common interosseous, anterior, posterior interosseous. If you find those, you'll be in good shape. This is the path of the brachial artery that you should appreciate. The biceps brachii, the muscle here, inserts onto the forearm in two places. One is it inserts on the radial tuberosity, right there. And the other is that it fans out, and actually the insertion becomes part of the deep fascia of the forearm. It inserts into the deep fascia of the forearm. So it's not a bony attachment, but yet it still can pull up the forearm because it's pulling up the deep fascia in terms of flexing it. The brachial artery, as you see here, as well as the median nerve, travels down on the medial side of the biceps brachii. The medial side of the biceps brachii. So you definitely should be able to, as I've mentioned before, that this is the biceps. It's right there in that groove. So that's where you'll feel the pulse of the brachialis, or the brachial artery right there. And in the muscle itself, you can feel right here the muscle insertion into the aponeurosis. And then on the radial side, you can feel it right there. That artery goes through those two insertions, as you see in this illustration up here. Goes between the insertions. Now, the fact that this artery and this nerve are below the aponeurosis there is good for you. Because the first time you draw blood from somebody's cubital vein, which is in the subcutaneous tissue, if you feel a pop and you start seeing a gush of blood everywhere, that means you popped through that aponeurosis and now you stuck that needle into the brachial artery, which is not really what you want to do. Okay? So you want to stay pretty superficial, and you will be drawing blood on each other. Let me give you a tip. I would be Kim's partner because she's an RN. So if you're going to get stuck, she's the one I'd get to stick me, right? Are you a phlebotomist? Anybody else in here a phlebotomist? Oh, look, these guys, hook up with them. Are you a phlebotomist as well? Hook up with them. You other people, y'all are, y'all are rude.
Stab you? No, it's not. Was that the first? You suck. You missed. Did you like miss it?
You know, that's not until next fall. You got plenty of time, to establish that relationship. Lighten up, we've been on shaking hands. A couple of other things that are in this illustration here that you really ought to take note of. Remember when we were drawing on the board yesterday, the brachial plexus, and we had two M's. The first M, the most distal M, you can see it right here. The musculocutaneous, the median, goes back up, and there's the ulna. Okay, the ulna is right there. Now, there are two other, so the ulna is the medial cord, right? It comes from the medial cord. Also from the medial cord is the median brachial and median antebrachial that were in the dissector yesterday. These are cutaneous nerves. This is the median brachial, and then the median antebrachial is going into the forearm. What cadaver was that yesterday? It had the nice has the nice median antebrachial, and I was asked, where's the brachial? The brachial, if you remove the skin, you pretty much cut it. Okay? around different parts of your body, especially those that where tendons rub on things, where muscles rub on things, you have these things called bursa. You have a bursa.
I have bursitis.
You all have bursa. You have bursitis of what?
I don't, he just said in my knee I have bursitis, I don't know.
Like generalized bursitis?
I don't know.
Her knee.
In her knee.
Oh, your knee.
Yeah,
Oh, yeah, your
yeah,
knee.
my knee.
Okay. I'm sorry, I didn't hear the knee.
Oh.
You're like, I have bursitis. Where?
Oh, it's in my knee, I
I
thought
didn't-
there was like different kinds, I was like, oh, I don't know.
I didn't catch it. Most common cause is gonorrhea.
And running.
So you're gonna put that on YouTube, so your mother may have an opportunity to see that. So you have bursa all over your body, and you also have one here on your elbow. It's called the olecranon bursa. And this thing is very easy to, normally you have just a milliliter or two of fluid in there, little slick fluid. These flat sacs allow for frictionless motion. In periods of overuse, like if you were to get out and walk up and down a bunch of stairs, or that 13-mile half marathon or whatever, then these bursa can become inflamed. That's bursitis. And the fluid inside those bursa can accumulate. Olecranon bursitis is something that's quite common. People get it, like carpenters or golfers, or all sorts of people can wind up with olecranon bursitis, and it's very easy to drain. You just do it in the office. Most of the time it'll fill right back up, but it can be like a golf ball sized, how would you characterize it? Doughy, liquid-filled mass. So it's pretty easy. You just clean the skin, stick a needle in it, draw it off, and most of the time what will come out of there is that clear to yellowish filtrate of plasma. That's all it is.
Do you ever x-ray these, or do you pretty much, can you tell from the MOI that it's bursitis versus, because it's
Yeah.
kind of deformed?
Yeah. No, as long as there's been no specific trauma, I don't x-ray them. Now, this is different than if you have, like, I'll go back over here in just a second. In this example here, you've got a hot, red, swollen, inflamed joint. This is not bursitis. This is an infected joint. That requires a whole nother mechanism of treatment. Bursitis, if it's just an inflammatory process, is simple enough. You drain it, you go on your way. Of course, one of the complications of draining bursitis is that it wasn't infected, and now you stuck a needle in it, and you got it infected from the skin. So that's always a potential complication of draining anything. The thing about the knee and the shoulder, you have a lot of bursa around the shoulder, in and around the acromioclavicular area, is that the bursa in the shoulder communicate with the joint, with the capsule itself. And it's the same in the knee. You have a bursa above the knee, you have one in the back, you have one below the knee. But these things communicate with the joint. So when you have bursitis of a knee versus an effusion of the knee itself, those are two different processes. All you gotta do is drain the bursa and you get knee fluid. You drain the bursa in the shoulder, you get shoulder joint fluid, because the bursa are connected to the joint itself. The capsule around the elbow does not communicate with the olecranon bursa. It's separated. So if you think you've got a hot joint, you've got to go into the joint, not into the olecranon bursa. Okay? You got to know which bursa do communicate with the joint itself and which ones don't. And the bottom line is, if you just say the shoulder and the knee do communicate, everything else doesn't, you'll be safe. Now, you guys have a question over here.
Can you bust your bursa set? My brother played baseball one time and his knee got huge and they said he busted his bursa set. Is that the same thing?
His knee got huge?
Yeah.
No, he had fluid inside of his bursa and his knee itself.
So
Yeah.
that's bursitis?
Bursitis, yeah,
So it's the same thing?
yeah.
Okay.
And so if you're gonna drain a knee, see, if you think you've got a septic knee, if you think you've got an infected knee, you don't have to stick the needle in the knee joint itself. You can actually stick the needle up here and drain off bursal fluid that is essentially knee fluid, because it communicates. That way you're not sticking a needle into the knee joint itself. Question up here?
So by communicate, do you just mean like the fluid can go through the bursa?
There's a connection, a passageway, yeah. Okay. Like I said, most of the time, these things fill right back up. The way you can help prevent them from filling back up is to, after you sucked off the, withdrawn the fluid, inject in a little bit of steroid, and then put an ACE wrap around it to give it some pressure, and that way the, it doesn't typically swell back up, fill right back up with fluid. Right? And the steroid that you inject into the bursa is enough of an anti-inflammatory that it keeps the bursa from secreting more fluid. Okay. Septic joint. This is a nursemaid's elbow here. You get this from when moms or nannies grab kids like this and come on, let's go. And they pull it, they pull them, and what happens is they pull the radial head out of the annular ligament. They pull the radial head out of the annular ligament. As you see in this illustration right here, it's free floating out here. So that's a subluxation of the radial head. The way you get it back in is pretty simple. You just put your thumb on the radial head, you supinate the arm. This is supination, this is pronation. You supinate the arm as you're trying to drive that radial head back into the ligament. If you can't get it to go back in just by supination, you do supination and you start flexing the elbow. It usually goes back in pretty easily. And you don't have to use a lot, you don't have to use sedation like you do when a joint is out.
When it happens, can you see like the head of the radius, like a lump kind of sticking out, or does the
Not
arm just look
necessarily.
weird?
The kid comes in though, they're in pain and they don't want to move. They don't want to pronate or supinate the arm. Okay. You talk to them about how this happened, and they say, well, I reached down and grabbed him in the grocery store and pulled him, and you can pretty much assume that it's the radial head. It happens in little kids. It doesn't happen, it wouldn't happen in Larry. You can't pull him hard enough.
That happened when I was 2 years old, actually.
It did?
Yeah.
It usually happens to very bad children.
Might have been a little ornery.
Little ornery,
just a little
yeah.
bit.
So did they take you to the emergency room to get it back in?
Yeah.
Or did they reduce it into?
Yeah, they took me, I guess, to the doctor. It happened during the day. And
Yeah.
he gave me a quarter or a sucker. Of course, I picked the quarter and put my radius back in.
How about that? Okay.
It's probably stupid, but would you ever see someone like a kid with this fracture and think that it was,
It's not
or
a
no, I'm
fracture.
sorry, but would you think that it was child abuse at all, ever? Or do you just always assume like, oh, the mom probably just didn't realize when they were grabbing the kid?
I think that depends on your definition of child abuse.
But typically you would just.
Typically, I don't want to say typically you would or typically you wouldn't. You'd get the history.
Okay.
If it was just Junior was acting up and I grabbed him and pulled him, Probably not. If Junior has bruises that are different stages of healing, then I would probably say there's more going on than just a tug. So you're gonna have to get the history on this.
I've also seen him just picking them up, like grabbing.
Well,
their
yeah,
wrists,
swinging, you know,
Picking them up to.
grabbing a kid and swinging them, can also do it. Yeah. It doesn't necessarily have to be come here. All right. This is something you're going to look for when you're dealing with occult fractures. Occult means hidden. So it's a fracture that may be hairline or something, you just can't really identify it that well. In the front and in the back of the distal humerus, there is fat. And during a trauma, there's swelling there that lifts that fat essentially up off the bone. And when it does that, it produces a different density. So over here, you might have to turn the lights down on your computer. Over here, that's the normal front, anterior and posterior part of the humerus. Over here on this illustration, you see that lucency right there and right there. You see it? That little lucency? That's called a fat pad sign, which means there's a fracture there somewhere. You're just not getting it on X-ray. You don't have the right view, or it's just too small of a fracture. So when you get X-ray reports back, you're going to be looking and trying to, is there a fat pad sign? If they say there's a fat pad sign, there's a fracture that you got to go find. This is probably the weeniest picture of a tennis player I could find. This guy definitely got his butt whipped in high school for several reasons. One is his hair. Two, he plays tennis, not football. And three, he's got a tennis elbow compression thing on. So let's review the anatomy here. If you feel your arms here, feel right here and extend your wrist. You can feel that's where the muscles are tightening up right here on the lateral epicondyle. So that's where your extensors originate in the lateral epicondyle. Tennis requires that motion. Repeated and overuse or poor stretching of the extensors prior to the activity can produce tennis elbow. The grown-up term for that is lateral epicondylitis. Conversely, golfers, when they, in a golf swing, what you're doing is you're flexing. And so they wind up with a medial epicondylitis. That's golfer's elbow. One way to treat this is, if it's severe enough, well, what you want to do is you stop the activity, put them on a non-steroidal anti-inflammatory like ibuprofen, maybe some heat to the area, or ice to the area after the activity. You want to rest it as much as possible, though, but a lot of times people won't decrease the activity like they're supposed to give it a chance to heal. You can use one of these bands here. The purpose of the band is you tighten that band down, and what it does is it sort of serves as an artificial site of origin. So it takes the pressure off of the lateral epicondyle. If that doesn't work, then you can resort to injecting the area with steroids to try to decrease the inflammation in the site. One of the problems with bathing tendons in steroids, though, is that they will weaken the tendons, and you could wind up, one of the complications of repeated steroid injections is tendon rupture. Now, the muscles of the brachium, there are two compartments. There's an anterior compartment and a posterior compartment. There are three muscles in the anterior compartment. The first one is the biceps brachii. And the biceps brachii, here are the two sites of insertion, by the way. The biceps, as the name implies, has two heads. The long head of the biceps is this one right here. It runs through the intertrabecular groove and inserts on a tubercle on the top of the glenoid cavity. So if you do this, flex your elbow here, you can feel that tendon wiggle up here, okay? The short head of the biceps arises from the coracoid process of the scapula. You want to make sure you identify both of those in lab. Short head, long head of the biceps. Now, there's another muscle that arises from the coracoid process, inserts into the humerus itself. That's called the coracobrachialis. And then there's another large muscle that's deep to the biceps, arises from the humerus and inserts down onto the ulna here. That's called the brachialis, or brachialis. Most of the, when they do this right here, and you've got that big bump right there, most of that big bump is brachialis, not biceps. So you want to be able to isolate those three muscles in lab today. And it's very easy to do. It'll take you like 1 minute to do that. You follow the arteries down, and the profunda brachii is going to come off right around here. On the extensor side, so we'll have to flip the bodies over. I want you to be able to find the supraspinatus and the infraspinatus, teres major, teres minor. Clean those up, identify them well, and then you're going to look for the three heads of the triceps. You only have one muscle in the posterior compartment. Three heads of the triceps. The long head of the triceps attaches to a tubercle on the inferior part of the glenoid. So if you look at one of the scapulas downstairs, if you have the glenoid cavity there, and you're looking at it, there's a bump up here and a bump down there. That's the long head of the biceps, long head of the triceps. That's the long head. That over here is what's called the lateral head. The lateral head arises from the humerus, and in between the two is a medial head. It also arises from the humerus, and it's not that well defined. All three of them come together to attach to the olecranon and are responsible for extension of the forearm. Because, now this is what you also need to keep in mind, when you're dealing with function here, which ones cross one joint and which ones cross two joints. You understand that the long head crosses the shoulder joint, and the long head of the biceps crosses the shoulder joint as well. So when you're talking about muscle function, it might extend here and flex there, depending on one joint or two. Okay? These, all three of these muscle heads here are innervated by the radial nerve. Now there's another muscle in the posterior compartment that is a very worthless muscle. You'll see it right here. It's called the anconeus. It's a cute little muscle that's actually down here by the olecranon. It stabilizes helps stabilize the elbow, but I think somebody just made that up. It's too small and too stupid looking to actually serve any function. So the anconeus. you'll see it on your body and say, oh, there's the anconia. I've never known an anconiositis. I've never treated an anconius injury, you know, so, I don't know why I said it. Any questions about the muscles? Now, here's something you ought to also be able to find pretty easily on your body, your cadaver. I would cut on one side the infraspinatus muscle and find those supraspinatus artery and vein coming around the spine of the scapula. Understand that these guys innervate both the supra and infraspinatus muscles. And to do that, just shell out the muscle from in there. Don't be gentle. Cut it and peel it out of the fossa there, and you'll find the vessels pretty easily. Right here below, there's teres minor, because you see that goes to the joint up here. That's teres minor. That right there would be teres major. That's down here on the humeral shaft. So right under teres minor, and right there by the long head of the triceps, there's a space that's a square. That's called the quadrangular space. Coming out of that space, you're going to find the posterior humeral circumflex artery and the axillary nerve. You find them right there. Remember I talked to you yesterday about dislocation of the shoulder? That you're going to get the axillary nerve? There's the shoulder joint right there. If that thing pops out of there, where's it going to go? It's going to go right there. That's why the axillary nerve is so in jeopardy with a shoulder dislocation. Why does the shoulder dislocate inferiorly like that? Because you got the sits muscles and the ligaments over top of it. All right?
When would the supraspinatus artery be considered the posterior circumflex? Because are those the two that anastemize?
Posterior circumflex. You mean off the subscapular?
Or is that the subscapular?
This comes off of the trunk. Remember from the subclavian? This is coming from the trunk, along with the transverse cervical gets the rhomboids. This also comes off the trunk and gets the spinatus muscles. Those are the two branches that go across the posterior triangle. Remember the trunk here?
Does it not, maybe I'm getting them mixed up. I thought
No,
that,
you're right. No, you're headed in the right direction. This artery is going to come down and anastomose with the circumflex scapular off of
Oh,
the
no,
axillary.
humeral.
I think that's what you're trying to.
yeah.
Yeah.
At what point does that happen? Like when would you tag it really obviously?
No, you
like,
could not identify I would either tag the supraspinatus up here, where it's obviously that, or I'd flip the body over so you could see where you'd see the circumflex scapular coming off of the axillary. You could follow it to the axillary. I'm not going to be tricky here. I'll say a little bit inferior to that, there's a little triangular space here. If you peel back the heads of the triceps, you'll find the radial nerve and the profunda brachii, or the deep brachial artery, in that little triangle. Remember we talked about a mid-shaft humeral fracture, possibly cutting the radial nerve? That's because it's right there. There's the spiral, that would be the location of the spiral groove on the humerus right there. This will take you 45 seconds to find. You'll be out of lab today in 3 minutes. Right, it'll take you longer than that. So do both sides. All right, here's a summary of the muscles here, showing the muscle, its origin, insertions, its innervation. Innervation of the anterior compartment is musculocutaneous. The innervation of the posterior compartment is radial. We're done. And there's the action right there. Primary action of the anterior compartment is flexion of the forearm. There's a little bit of rotation associated with the biceps, but not much. But anyway, not much to speak of. We're going to say that flexion is the primary motion, and in the posterior compartment, it's extension. And here's the rest of the muscles here. They glorify the anconeus, assist the triceps, and extend the forearm. The anconeus is like this big, and the triceps is that big. So where is the assist? You're going to find another one down in the knee that similarly is stupid. And also in this one right here, that one right there, palmaris longus, stupid. You're going to see it tomorrow. The belly of it, yeah, is like, you know, you have eyelashes bigger than the belly. This is a ruptured biceps tendon. When tendons rupture, either the Achilles or the biceps, the muscle belly pulls, and what you wind up with is a knot in the mid-humerus region. This is me right here. We were talking about T4 and T5, and now you're, okay. You see the big lump of the muscle belly from this person's obviously going to be in pain, and what you have to do is take them to surgery and pull that thing back up and suture it back in place. This is something you're going to run into clinically a lot. We talked about the basilic and the cephalic veins yesterday. They're more useful than just drawing blood out of the cubital fossa. If you have an IV in place in the back of the hand, that can really only stay in there for about 3 days. In 72 hours, about the length of time, and then they have to change it. And putting an IV in hurts. So getting one of these things in every 3 days, if you're hospitalized for a long period of time, or if you need intermittent, like antibiotics or chemotherapy drugs or something like that, it's not a good thing if you're doing long-term, you need long-term venous access. So this thing is called a PICC line, and what these things do, they're placed in under fluoroscopy. Really, you use a ultrasound to identify the basilic vein, and you thread that catheter into the vein, and it's a long catheter, goes almost all the way to the heart, and that allows you to put larger volumes, and you can leave a PICC line in place for a long time. I can't remember how many weeks a PICC line is good for, but it can be a pretty long time, and you only have to have one stick, and that's what you see here. That's going into the medial side, right here, into the basilic vein. And you can see on the x-ray here, that little thin line, that's the PICC line itself. It shows up on x-ray.
How do they decide between, or why do they do a PICC and then why do other times they do a port?
It also depends on the volume of what, like if you're going to do chemotherapy drugs, most of the time they'll stick a port in where it's right up underneath your skin, and they just stick a needle through your skin into the little rubber thing of the port and inject it there. The port is connected to your vasculature as well. I think more volume, you get more volume into a port of nastier stuff than a PICC line. PICC lines are very commonly used for long-term antibiotic use.
Is a PICC line and a central line the same thing?
No, central line is different. The central line goes into the subclavian and is bigger. It has most of the time it has 3 different catheters in one. You thread that down to essentially through the superior vena cava to the heart as well. But it goes in the subclavian vein. This is done, you can do this in the office. Subclavians are usually done in an emergency room or in the ward. The complication of the subclavian is since you're going right here, you wind up with a pneumothorax. Remember, the subclavian vein is right up underneath the clavicle. you ought to look at that on the cadavers. The subclavian artery and the subclavian vein, you need to look at that downstairs. The subclavian artery, remember, goes through the split between the scalenes with the brachial plexus. The subclavian vein is superficial to it. It's superficial to the anterior scalene. You need to make sure you see that down in the lab. Hidradenitis suppurativa, I mentioned that the other day. I put it in here just because we're doing this area of the body. This is the surgery that's done to cure that. They go in and strip out all the glands in the subcutaneous and the dermis and do a skin graft here. So this very irate looking guy has had the surgery for his hidradenitis. This is an interesting thing you get asked about all the time. People come to the clinic. It's called familial keratosis pilaris. And it's a genetic disorder. If your skin is rough right here, and you got the little red bumps right there like you see on that, you got it. And you inherited it from either your mama or your daddy. But it is a genetic condition. And people are always coming in complaining about the acne they have back here. It's not acne. It's a condition of the follicles, and you don't really need to do anything about it. You just got it. So, anybody here have it? Come on, be honest. Yeah, we got a couple people here. Mostly fair-skinned people. It's more obvious on fair-skinned people than dark people, but you can still feel it. It's kind of rough.
Chicken skin.
Huh?
Chicken skin.
It's what?
Chicken skin.
Chicken skin.
As if you like pull out all the feathers of a chicken, it's like bumpy like that.
Yeah.
That's what people say when you come to chicken.
They got chicken skin. Yeah, I can understand that. I can see that.
Is it only on the arm?
It's only on the extensor surface of the arm.
Can it be treated by anything? Like a
I
dermatologist?
would just tell people to use lotions like Lubriderm, Aveeno, keep it moisturized. It doesn't really respond to steroid creams. It's just the way you are.
Seems to be worse in the winter, though.
Worse in the winter. Yeah, worse when you're filming Shameless. Who else had it over here? Yeah, is it pretty pronounced?
It depends, like she said, like sometimes it gets bad and sometimes I can't even tell that I haven't.
Yeah, it does wax and wane.
Yeah.
You never heard that term?
No, I did say that, but I didn't make the noise in response to that phrase.
Oh, wax
That
and
is
wane
funny.
means it
You
comes
just
and
don't hear
goes.
it every day.
You what?
You just don't hear that phrase every day.
Oh, yeah. You make fun of it. There was a question over here. We're good? All right, let's go to lunch.